And if everybody agrees, we will start with a postgraduate course. We had 3 sessions of the postgraduate course. Let's start with number 1, with session number 1. That was innovations in radiology, endoscopy, and robotic surgery.
Yes.
Could you take out highlights for you?
Well, I think each talk I went away thinking, okay, now I have to change the way I'm thinking about it in my practice. But I think the one that first and foremost for me was the endoscopy. Yeah. Because, we're gastroenterologists, so we do endoscopy, but this was a whole nother level of endoscopy, this, endohepatology, really showing us the immediate promise of really taking on much more that we can do endoscopically. We can measure portal pressures, we can put in tips, we can take a liver biopsy, all of that kind of coming under our umbrella, where that previously lied with interventional radiologists or others. So for me, that was very, very exciting. I think as a whenever you think of divisions of gastroenterology and hepatology, this is a way to partner either with our advanced endoscopists, or moreover, maybe this is the new way for hepatologists to be trained.
And what Professor Wim Laleman said, it's all in one package. So it's the future. So giving propofol to the patient, doing the EUS, the endoscopic ultrasound, doing the measurements for flow and pressure, and then taking a large liver biopsy. And the patient becomes awakened after an hour and goes home. So I was impressed about that.
It was. And they actually highlighted that the biopsy quality is actually better than percutaneous, which I was quite surprised about. I didn't realize they do 3 passes, which is, so they have a lot of tissue. So they really make this point that they're getting high quality material for a liver biopsy. Patients are happier because they're sedated and they're out and they go home quickly. So I can just sort of see that this is going to very rapidly, I think, move towards something that might become our standard of care.
Yeah, I think in 5 years from now, our young hepatologists, they will do these things. I hope so. A moment for tips, because I was amazed about this talk from Chicago, Riyad Salem, who showed us what you all can do with tips.
It was, I don't know about you, but I went away thinking there is no thrombosis, portal vein thrombosis, that can't be fixed. From the point of view of placing a tips and establishing flow is really remarkable. I'm aware of that group from Northwestern. They're very skilled and they've been publishing in that space for quite a while. But I think he really made very compelling story around the idea that it's important to improve portal flow, right? I think in the past when there's been a portal vein thrombosis, like, okay, we got that complication, we have cavernous transformation, we're just going to have to deal with the portal hypertensive complications, right? And I think he makes the point that we don't have to. We should be thinking about how do we establish flow. He emphasized his splenic approach as being one of the key kind of steps that allowed them to become much more aggressive about their tips placement, but it was an impressive talk, I thought.
Impressive. Highly skilled. This cannot be done in every center. This is highly skilled center in Chicago. But I remember his sentence, there is no more untipsable patients. So thanks for the moment.
Thank you.
I turn over to you.
Yep. Okay, thanks. Because in parallel, we also, next to the postgraduate course, we also have the basic science seminar running for 2 days. And this year it was on emerging concepts in metabolism, both in health and disease. You also had 3 sessions today. So to the first session, what were really for you the emerging concepts?
Well, so I think, metabolism as such in the liver has been underestimated. Metabolites either coming from hepatocytes or immune cells, or even from the microbiome, right? I mean, it's really impinging massively on the mechanistic underpinnings in the liver. May this be what type of immune cells enter the liver? May this be how hepatocytes proliferate or don't proliferate, present antigens, and at the end of the day also how they respond to therapies. So we now know that, and we and others actually have published a paper last year back-to-back in Nature where we show that NASH in particular changes the response efficacy to immunotherapy. And however, it's also very nice to see that, there is not one type of metabolism. There is so many flavors when you look at patients. So there will be also NASH patients that respond pretty well to particular type of immunotherapies. Himalaya trial has shown it. Anti-CTLA-4 combination with anti-PD-L1 works in some of the patients. So why is that the case? Well, because some of these patients apparently have T cells that you can still tickle to induce tumor surveillance. So in general, but jumping into the first session, I think that people start to understand that metabolism is a new field of cell crosstalk that is a new level that is not really investigated in that detail, and it changes the paradigms in how we think about how liver works. Also, I think in the clinical practice it will change what type of metabolites will you use as markers to stratify patients for particular therapy responses, or even for risk stratification per se. So I think this will become really a big topic. By the way, what also these second session has told me, there are many roads to Rome, but I'm not sure whether all the roads to Rome will lead to the final goal to get into the clinic. So I think we have to accept that, we will come up with a lot of dreams of potential targets, but at the end of the day, there will be only a handful of targets that will really make it into the clinic.
But that's what basic science is for, right?
But you have to believe. At the end of the day,
understand.
You have to believe in it, right? You have to believe in it, and we have the same mission and dream, and you have to see how far you can go.
You want to know how it works.
Yes, how it works, but I also want to know, and I think that's really what is changing in science, how it works in patients, and can I make the efficacy better, not at the cost of adverse effects in the patients. I think that's really where we're at, and at least this, what I'm talking about, will become a new era of research and a new era of clinical research, right? How can I make a drug better that I have as a starting point without affecting the patient too much, or even reducing adverse effects. So that is, I think, that was in this cancer immunometabolism session really clear to see. There was a talk on P53 and how P53 tumor suppressor is actually also mediating metabolism, and also super fantastic. Like we think about P53 as everybody would say, it's a tumor suppressor and it's just important for cancer. But we now know, there are many papers also in PDAC that playing around with tumor suppressors or oncogenes changes the microenvironment of the tumor in its own right. And again, complete metabolism, completely new concept, right? That you according to what type mutation in P53 you have, you might have a different flavor of metabolism in the liver. So that was again astonishing. And the third session,
very short.
Yes, very short. We make it short. Immuno-metabolism. Very very interesting highlight was NASH is an autoaggressive disease. So it's a disease that is triggered by CD8 T cells that do not recognize antigens, but that are metabolically activated to kill every type of cell they see. And this metabolic activation generates a pro-inflammatory, pro-cancerous environment. And if you go in with immunotherapy, you stabilize these cells because they are PD-1 high. So these are CD8 PD-1 positive cells. So this was a highlight, I think, because it again changes how we look at NASH and how we look at treating this disease.
Helena, can we talk about the postgraduate course a little bit? Because today was the second day and also the last day of the postgraduate course. And what was your highlight from today's part of the course?
Well, first, thank you very much for inviting me. I really enjoyed the postgraduate course. In fact, it was a little bit different from what is usual. And this concept of the personalized medicine, I think it's very much in the future. And I liked particularly two talks that I found very interesting. One was from Rita Lomba about NAFLD and personalized medicine. And he very much highlighted the importance that we'll have in the future to better know if, for example, our NAFLD patients are most genetically based or metabolically caused, so that treatment can be, in fact, directed to what are the causes. And, of course, this have also implications to the clinical trials, and it's possible that many clinical trials do not show effect because they are not being applied to the right patients. So I think that increasingly we are going to be focused on personalized action and to know exactly what kind of patient we face when we decide the treatment.
Just to add something, it's possible. The interesting point in the NASH genetic predisposition factors, before we previously identified first PNPLF3, and after a second gene that predisposed to NASH and HCC also, TMCCSF2, and additionally a third one. If you take the genetic risk factor alone, it don't predict a lot the disease because the odds ratio is low. But if you add every genetic factor together, it increases the ability to predict patient to develop cirrhosis with NASH. And that's interesting. It is a combination of genetic risk factor, and previously we have only one, and there is a low level of prediction. I think it's a very good point.
And now we also see that there are some genetic factors that are protective.
Yeah.
So we could try to silence some and to put the others more active.
Yeah.
So I think there's a whole world of news to get from there. And then the other also very interesting talk was from Peter Gall and HCC. And in fact, it's quite impressive how much we lack biomarkers for our patients. So we treat patients according just to their stage and to the severity of the disease, but we do not yet put treatments directed to the mechanisms or to, as for example in the breast cancer, they are very much in front on that. So I think it's something that we have to work much more on defining specific biomarkers for different kinds of liver cancers, and then of course to direct and to target treatment according to what is found. And of course, he also highlighted what I think that most of us do in our clinical practice, the need for the multidisciplinary teams where each patient is discussed in great detail. Because in fact, each patient is always different from the other. And it would be very good if in the future we can further direct it. And the other point he also mentioned that I think we are going to increasingly see is the combined treatments. Mm-hmm. So probably we cannot stay just with one treatment. So I think we are going to see much more combined treatments and also combined local regional treatments with systemic therapies. So I think it's also a field that is really growing and as we are seeing increasingly more patients. But both there were a lot of other very interesting things in the postgraduate course, mostly with artificial intelligence, but I will not go on that. I think it's quite puzzling.
But just to jump in the discussion about personalized medicine in HCC, I liked also a point that the non-invasive diagnosis of HCC have decreased our ability to identify biomarker because we have no tumor biopsy, and especially in advanced stages. So maybe in the future, for advanced stages, maybe tumor biopsy and biobanking for sure in clinical trial should be mandatory. If not, we never identified any biomarker to stratify patients for sure.
Yeah, I completely agree with you. The fact that we decided at a certain point that our cirrhotic patients did not need to do liver biopsy if they had all these criteria, in fact, led us with less material to study and to discuss. I'm not sure to which extent the liquid biopsies in the future and getting markers from that are in the blood will help us with that. Because I'm not sure if anyone wants to come back to doing liver biopsies to the patients in a regular basis.
One of another point that had been discussed during this meeting in several presentations is the impact of gender disparity and disbalance in clinical trial, in organ allocation, in the male, for example, for allocation of liver graft. So can you tell us a little bit more about gender disparity and in liver disease.
Yes, with pleasure. Yeah, it's true that EASL, it's highly implicated in gender, equality in many levels, and it's not only having the speakers and the conference with gender balance. It's also considering the patient's treatment and management, and how we can decrease gender bias in this regard, and also how can we improve also woman career and female role model, like I told you with Sabina Lenz, where you get inspirational talk. So I will go back on the patient treatment, which is a part that usually we talk less about regarding gender balance. And yes, today there was several talks. One on clinical trials where Mads Israelsen talked about the rifaximin alpha to treat alcohol liver diseases. And it was very interesting talk. And he himself said that there was 83% of male in these clinical trials, which make it not really we can't really apply it for women. So it's a very interesting clinical trial with a nice effect on this drug, but then it's probably only for male. And this has been the case for a lot of clinical trials and a lot of drugs that we are now using for female and for male, but has been validated only or mostly in male.
And Jean, can you hold that thought for a moment, because I want to ask Alexander, because he was obviously heavily involved in that trial. So we've heard that this took a long time for you to actually finish up. Can you and also with regards to the gender disbalance thing, can you tell us a little bit about how this trial evolved and what the hurdles were that you have to overcome in performing this
First,
trial?
I want to say, and also with Mads, who is sort of leading his lives, it's not because he was lazy, but doing randomized clinical trials can be really tough. And I think this is one of the first larger trials in alcohol-related liver disease. So I think it's really important just to showcase that this is possible. These patients, they can comply to treatment, they can do repeated biopsies. So we set off for that in relations with the Horizon 2020 grant, the Galaxy Star consortium there, and that's almost 7 years ago since all these ideas was initiated. And then you set out to do that. We had very ambitious, we had 136 patients in a randomized setting, 18 months treatment, dual biopsy. It looks very beautiful on paper, but then unfold it and follow it to an end. That's not really easy. So we went through, and there I just have to admit that we sort of stratified on degree of fibrosis in the liver biopsy and on level of alcohol consumption. But probably we should have considered gender too. Because we ended up, because that's the way it is sometimes in clinical trial, you need the patient, and they fulfill the criteria, you simply just add them. So I think there's also kind of a bias with alcohol reload. There is probably more men, and that's the issue. But I don't really know how to overcome it, but I agree with you, just like we know from many other things, it's relevant to have it across different races. It would probably really be important to do some sub-analysis to see, do you see the same directions also for gender?
Just one question. There is a lot of patients that refuse to participate to the trial. Any difference between men or women in terms of...
No, not statistically significant, but of course that will go for any trial. A patient that is able to comply and really understand what's going on, have a liver biopsy, take a drug twice a day for 18 months, meet up for repeated biopsy, that is already a little selected group. So in that sense, but I think also going forward, if you want to apply this kind of treatment, you need patients who are also kind of compliant, who are motivated to go in there. So I think the issue was staged because we want really to screen very wide. So anybody within the field, you do a FibroScan, you go into this, and then you ask patients. So that was basically the filter. And then you end up with many who are really ineligible, and I think there was around 200 that were potentially eligible but didn't want it. And mainly liver biopsy is a barrier to many, but also the length of treatment. And we also have to recognize that many of these people are not partly marginalized, meaning that they're also, it's difficult for them to go back and forth for all the assessments. and there's also cost side there, etc. So there are some barriers that it's difficult to do studies in less privileged patients.
An interesting point about gender bias in HCC, for example. 2 points: if you search for in PubMed clinical features, prognosis of HCC developed in women, there is very few articles. So, okay, it's most frequent in men, 80% men, but very few articles that target the HCC in women. It's not very frequent, very few publications. And the second point, in basic science, people use only male mice to do all the analysis of HCC development in mice, because there is a higher rate of HCC incidence in mice, male mice, so it's more easy, but there is also HCC in female mice. So almost all the basic study about HCC are developed in male mice.
Yeah, it's the case for many subjects, because it decreases also variability, because male and female are not the same, it creates variability, which is more difficult after to show some statistical effect. So it's easier to work on the male group, but then if you do that, at least do it also in the female group, if you want to have two homogeneous groups, but doing it both, if you don't mix them, at least do it. Yeah.
So anything else that really caught your eye today?
Well, I was at this ACLF session this morning that you were chairing, and there was this study of Engel coming from Padova. Engel as a new biomarker of HRS. And I thought it was really interesting because we are sometimes struggling to say, well, my patient has renal failure, is it HRS, is this tubular necrosis, is this something else, hypovolemia, and what to do with that? And so Engel is a new marker. I don't have the experience of Engel myself, but I know that we could do it. And here, this was a large series of patients who were included from Padova, and the Engel was studied. So at 39%, as far as I remember, of the patients had HRS, and Engel was significantly more elevated, a lot more elevated in patients with HRS. So it was very useful for the differential diagnosis of HRS. And then also in those patients treated with terlipressin and albumin, I must say that Engel, with certain values of Engel, I think it was 220, but I'm not sure, were correlated with the response to treatment and also mortality. So those results need to be commented, and I'm very happy that we have Pere here to comment them, but it caught my attention because I thought, well, maybe we will just sort out the story of is it HRS or not, and how should I treat it? So.
Yeah, Pere, I saw this morning you went to the microphone and had some comments regarding this study. And we know also that you have a great experience with Engel and published on that. So could you share with us your view and what is your take from this study?
Yes. Well, I think this was a very good study, and in fact, in the area of acute kidney injury and hepatorenal syndrome, we need objective markers, because so far the definitions for the differential diagnosis are, let's say, quite subjective. So it's difficult to make the diagnosis if a patient has acute tubular necrosis or hepatorenal syndrome or another cause of acute kidney injury. And the fact that we could have in the future biomarkers to be tested easily in the urine may help the physicians a lot when taking decisions about what is the therapy that should be given to the patients. And I think that this study is important because first it confirmed two important things about Engel, which is that it is very helpful in the differential diagnosis between acute kidney injury due to acute tubular necrosis or hepatorenal syndrome. So the levels above 220 are highly suggestive of acute tubular necrosis. By contrast, the levels below 220 are highly suggestive of hepatorenal syndrome. So this is the first important message.
On a practical point of view, it means if you have high level, you should not treat with terlipressin. Is that the clinical implication?
Exactly. So if the levels are very high, the suspicion is very high that the patient has marked necrosis or at least marked injury in the renal tubules. So very low probability of hepatorenal syndrome. Second message, yes, please.
But how do you approach the patient then? We only have one treatment. how would you approach this problem?
The problem of treating the patient?
Of the patient,
of course. You know, because the two important causes of acute kidney injury in clinical practice are hepatorenal syndrome and acute tubular necrosis. For hepatorenal syndrome, we have terlipressin, and we have the good news that terlipressin will likely be approved soon in the United States and Canada. Okay, it is available already in Europe and will be approved in North America. For acute tubular necrosis, we know that terlipressin is not effective, and we know that the patients, if they meet criteria for hemodialysis of other types of renal replacement therapy, they should go to renal replacement therapy until we have better treatments for acute tubular necrosis. So in this regard, the fact that we have something objective will make things much easier and will make studies much more comparable. Because so far, if there are no objective measurements, it is very difficult to compare studies from one to another. Okay. Second message is that those patients who have high levels of NGAL in the urine have a much poor prognosis. So this is also important with respect to the evaluation for transplantation. So this means that patients with high NGAL are more likely to die if they are not transplanted soon. And we have shown that the NGAL adds value to MELD. Okay. So a patient with high MELD and high NGAL has much poor prognosis compared to a patient with the same MELD and lower NGAL. So this is the second important message of the study. Third important message is that they found a relationship in patients with hepatorenal syndrome between the levels of NGAL in the urine and the response to terlipressin. And this is something that, if it is confirmed in other studies, would also be very important, because before starting terlipressin, we will be able to, anticipate which are the patients with a higher likelihood to respond, so to start terlipressin therapy. And this is important in the light of the results of the confirmed study, suggesting that some patients may be at risk of developing acute pulmonary edema. Mm-hmm. So in summary, this is, I think, is very important, adds to what we know about NGAL, and will probably change the next guidelines in the sense that probably NGAL will be incorporated.
But you have published already some years ago on NGAL. Are you using NGAL in clinical practice at your site?
We are using NGAL at clinical practice, and in fact we have a system.
How do you manage these numbers on a practical point of view?
Yes, what we are doing is that we are giving first albumin to the patients who have acute kidney injury for 2 days, and then if acute kidney injury persists, then what we do is that we measure NGAL.
In the urine?
In the urine. If we have a system that is called turbidimetry, in which we have the results in 3 or 4 hours. Okay. So you send the urine to the lab in the morning, and in the afternoon you have the values. Okay. So if the patient has very high NGAL, above 220, it's very likely that the patient has acute tubular necrosis.
And is there something about the volume of urine to take into account? Because we could imagine that if you have half a liter or 2 liters of urine per day, it might change the levels. Is that something to take into account?
This is a very good comment, but as with many other substances that are eliminated in the urine, if you factorize it by the level of creatinine in the urine, you eliminate the problem of low urine volume. Okay. So in fact, it is better to give the NGAL results by gram of creatinine in the urine.
Okay. Because actually, Per, in the session this morning, there was also another group that presented some data on NGAL in another abstract, but also they were looking at urinary microscopy and showed that there was quite a good correlation just looking at the urine, looking at CAS. What are your thoughts there? Is that something we could use?
I have spoken with several nephrologists in our hospital and in other hospitals, and urinary microscopy is something that the nephrologists in general sort of have abandoned over the years, and they do not use very much in clinical practice. And I think that the guidelines, with respect to the nephrologists use, do not incorporate the evaluation of urine microscopy. And in fact, in many hospitals, it is not available. The advantage of NGAL is that you could set up it in any lab. in any hospital. So
Or
it can be
in
available.
conditions that is not very reliable, which we would assume for tests that we would recommend in the guideline, right? Because if you're lacking the experience, then
Exactly. And NGAL is something which is very objective and low variability. So I think it's much better than something that can be more subjective.
Okay.
We also have today the late breakers abstracts, which was one of the very well attended sessions. Luca, can you comment on any of the relevant news that we got today?
The newer data on genetics I was also very excited about, and being one of the collaborators in my main field of interest. So Erika, I know you are also very interested in genetics of liver disease, so what's your take on the study and the novelties in the field?
Thank you, Luca. I think it was very nice study. It's you were part of the study, so you know it very well. But what is very nice, it addressed a major burden for liver disease, which is HEC, and it was alcohol-related HEC because HEC. You hear that NASH is contributing a lot, but Alexander, I'm sure you will agree with me that alcohol is still a major driver for HEC. And here, what they have done is they had a lot of cases in control, so they did what we call GWAS, which is the easiest way to look for like genetic variants that are associated with the disease. And they were able to capture the usual folks, so PNPLA3, TM6F2, and they found a new locus which is in TERT. So for the people that are involved in HEC, people know that TERT is really the first gene that is going to be mutated, is going to accumulate somatic mutation, and here they find a germline variant. And here it was protective, but depends at which allele you're looking at. So it was very nice because it also makes sense with the pathophysiology of the disease, because with this type of study, sometimes you capture things that are difficult to link with HEC. So it's important. It shows that the concept is nice. Obviously, they will need more patients, more power, and then they're probably going to find more and more genes. So it was very nice indeed.
And we will hope to translate sooner or later these new discoveries into new drugs or a better way to manage the patients.
Certainly, new drugs. Probably not prediction at the moment because we don't have enough loci. But for drugs, yes, I think it has been proven in the past in other fields. For example, coronary heart disease, and for hepatology, I think there's a huge potential there, but they will need more functionality, all these kind of studies that are, that should be ongoing now.
What do you see a future for silencing drugs? So what kind of drugs are relevant there? Because I think I was really fascinated that genetics has been around for so long. There's been done so many studies, but still, the more power we get, and the more we come up with new loci, and I think this was really surprising that this was really seems to be associated with significantly lower risk of HEC. Yeah.
Well, I think the potential is huge, but at the moment in hepatology we are suffering from one thing, is that the sample size is quite low compared to other fields, diabetes, Alzheimer, heart disease. So I think when we're going to have really the power and all the samples, because Luca is going to agree, it's something that is, genetics in liver disease is not something that is so old, that now we are really building consortium and things like this. So I think...
So why is that? Because there are 7,000 people here. Why can't they find the patient? This must be the perfect place to set up a big consortium, because I guess that's the way it works with these meta-analysis and stuff.
Indeed, it's a good question, Alexander. My view is that it's only going to work if we sit together and we put all the, we join forces and we do indeed this big meta-analysis. I think one of the reasons is that it's still new, so people are not used to it compared to IBD, for example. In IBD, they have been doing this for years and years. And we started a bit late, but we are catching up. But for sure, consortium will have to be built and people will have to, again, yes, put their force together.
Maybe I can ask, I'm so curious, Luca, because the big field here is NAFL, NASH, and so much are happening. And then, there was two big trials in NASH. So what do you make out of it? There was a semaglutide, was it the phase 2? And where do we go from here? Because that seems to be the big thing for Novo these days. So what's the bottom line of the semaglutide study there?
So I think semaglutide was confirmed to be safe, even from the data presented today in patients with cirrhosis, which was kind of needing a confirmation, and was effective in reducing weight on average of the patients, and some markers of metabolic alteration associated with weight. And so there is potential there that the drug will also be able to induce some benefit in the long term in patients also with advanced liver disease. I think this is important also because, I mean, this is one of the drugs that's already currently in use for patients with type 2 diabetes and obesity as well, so it's important.
Now the trials are starting also in cirrhotic patients, so really not just the fibrosis.
Yeah, I think that it was important to demonstrate it's also safe in cirrhotics because this will be facilitate the prescription, for example, the drugs in diabetic patients with cirrhosis without, for example, worrying about potential side effects related to the liver by showing that it's potentially already also beneficial in this subset of patients.
This is a multicentric study. We ran it, but it's actually thanks to all the collaborators of the International Autoimmune Hepatitis Study Group, and we wanted to see the incidence of HCC in these patients. So far we have 1,400 patients involved.
Wow.
And actually the incidence of HCC is very, very low. Really low.
How low
how low is like in the overall cohort is 0.7 at 10 years percent, 0.7% at 10 years.
Oh, in how advanced disease group?
And this is the whole cohort. If you look at the cirrhotic patients, it goes up to 3% at 10 years, but it's 0.3% per year.
Yeah.
So it's very, very low.
Would you screen these patients?
That's the point. That's the whole point. Nowadays, we surveil them as any other etiology, but probably it's not cost effective if this is confirmed. Of course, it's a retrospective cohort, but the good thing is that the follow-up is very, very long. We go up to 35 years of follow-up.
Now, this is really interesting, like many other things, but are there any then differences? I could imagine that those who are well controlled and respond well to drugs, they must have a lower risk than those where we have difficulties and they...
Absolutely. I know this is the main point. So we didn't see any difference in the type of treatment, so immunosuppression does not make any difference. I mean, the drug you use for immunosuppression. In terms of response, we see that the responders have lower rates of cirrhosis, so you would expect to have less HCC. The thing is that the numbers are so small that the difference is not significant. The other difficulty is that in such a long follow-up, it's difficult to establish the time of response. So what do you choose? At 1 year, at 2 years? It's a little difficult, but...
So the bottom line is basically that we shouldn't be that worried and can also tell our patients that even though we make surveillance, it's probably not the thing that just you worry
probably
so much
what makes the difference are comorbidities. Like we've seen that obese patients with autoimmune hepatitis do make more HCC. So comorbidities are key. Some patients probably still deserve surveillance because of other cofactors. Well, the work's still ongoing, so we need to see when we finalize all the data collection. But I think it's a strong message, and it's important to let people know and the patients know, because it's a disease, it's a chronic disease. They often start very young. They have their whole life ahead, and knowing that HCC is not such a big
it's definitely
risk, it's important for them.
Mexico.
Yeah.